Well, sacroiliac joint dysfunction, as you're asking me now, it's a very important source of pain in the low back, particularly axial low back pain. It is often missed and underappreciated by primary care providers and many even pain practitioners as well. The incidence of sacroiliac joint dysfunction reaches anywhere between 15 and 30% in the general population. So as you can imagine, it's almost up to a third of the individuals that have axial low back pain where the SI joint may be involved. The SI joint is the crossroads, so to say, in terms of the vectors from the lower limbs and the upper part of the body, where all these forces, when you're in a closed kinetic chain, all the weight that you're putting on the legs, it transfers back to the spine and from the spine down to the legs, and that's sort of like the intersection. And it's an important source of low back pain because it tends to get degenerated, it tends to be affected when there's any kind of malalignment, and it needs to be targeted if we want to treat effectively patients with axial low back pain. So how do we use joint injections for the diagnosis? Well, the use of joint injections is sometimes a little bit overrated, in my opinion. It is sometimes referred to as the gold standard to determine if that is where the pathology is coming from. However, the innervation of the SI joint and the contribution from some of the ligament structures is so important that if you perform a joint injection just going inside, interarticularly, you could potentially miss a lot of the other sources of pain that could be generating from the area of the SI joint and surrounding structures. Similarly, some of the denervation procedures, because of the complex and rather wide innervation of the sacroiliac joint, may in fact miss some of the structures that are, or some of the nerves that provide sensation from the joint. They are important, but sometimes the physical examination, certain physical examination maneuvers, and the history of the patient, sometimes way too often overlooked when these can be actually quite effective as well in conjunction with the injections. That's an excellent question that it's near and dear to my heart. I'm always speaking about that, about the lack of correlation between imaging studies and the actual pathology, and this is particularly true in the sacroiliac joint. It is, as a matter of fact, rather rare for somebody that doesn't have a significant traumatic event, even if some significant trauma, to have any findings in imaging studies in the SI joint. However, a lot of times these are overemphasized, or people actually are ordering too many of these tests when in fact their yield is actually very low to nothing at all. And that is one of the topics that I'm very interested in, particularly when it comes to many other areas of the body, particularly the spine, other areas in terms of bulging discs, herniating discs, shoulder pathology, labral tears and things along those lines, where a lot of asymptomatic volunteers, when they have actually done studies on folks that are completely asymptomatic, they do have pathology as defined by imaging, but they really do not correlate with any symptomatology because they're completely asymptomatic. The SI joint is particularly notorious for this, with the exception of patients that have spondyloarthropathies. These are folks that have rheumatological conditions where there's sclerosis and there's even fusion, a lot of inflammation symmetrically in the joints, and those are very easily seen in imaging studies. But other than those, the usefulness of imaging studies is probably very little to none. The part of the evaluation that I want to emphasize before you go into any kind of treatment, you have to do a good assessment of the patient. Part of that good assessment involves a very thorough history, both in terms of what kind of pain, for how long they've had it, where the pain is, etc., but also what kind of activities have either triggered or trigger the symptoms that they're experiencing. It's important to delineate if the pain is radicular versus non-radicular. Typically, the patient with SI joint dysfunction will present with a pain that tends to be axial or maybe slightly referred to the buttock or to the lateral thigh, rarely into the groin, but mostly into the pelvic area. And then you have to, after you do that, you have to try to figure out what is actually causing this, because SI joint dysfunction many times is the consequence rather than the reason for other problems. Patients that have malalignment of the spine, patients that have problems with varus or valgus of the knees, overpronation of the foot, and leg length discrepancies can actually be patients that will develop this. And the SI joint is really a consequence. The SI joint problem is a consequence instead of the cause of the problem. Now, once that's determined and you address, usually with physical therapy, stretching, core strengthening, and many other modalities, including muscle energy techniques and manual mobilization, there are a variety of different procedures that can be performed, including corticosteroid injections, proliferant therapy, amniotic fluid, amniotic membrane, commercially available injectables, high hyaluronic acid in some cases, and even radiofrequency ablation techniques. It's important that for procedures that are performed in the SI joint, we use appropriate guidance methods, imaging guidance. And traditionally there has been fluoroscopy, but nowadays more and more providers are using ultrasound guidance. Ultrasound guidance has the advantage of being performed at the bedside without the need for a fluoroscopy type suite, doesn't give any ionizing radiation to the patient, and it really can be done in any office setting.